Dah ready dah?
Yes, insyaAllah Datuk.
Semua ada dah?
Dah.
Okay, start.
Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh and a very good afternoon. I bid to our supervisor, Dato Dr. Fadzil and my fellow colleagues. So today will be the presentation of Teaching Seminar 5. There will be 3 topics that will be presented. Firstly is growth disorders by me, Shazwani, and then inborn error metabolism by Nura Atika, and last one is sepsis and septic shock in children by Asia Fariha. Okay, so first let's start with the first topic, which is growth disorders that comprises of the short stature and tall stature. So this is the outline of my presentation today. So firstly, I will talk about the normal growth phases, followed by physiology of the growth hormone. Then we will talk about the disorders, which are short stature and the tall stature. Okay, so the normal human growth can be divided into 4 phases, which are fetal growth, infantile phase growth, childhood phase, and pubertal growth spurt. So I will further explain the phases according to this graph. So this is the graph of male and female height velocity in the 50th centile. So the first one, we have the fetal growth phase. So this occurs in the intrauterine environment, and it accounts for about 30% of the adult height. And this is actually the fastest growth phase, and the maternal, placental, fetal, and also the environment factors plays roles in determining the growth of the child. Next, we have the infant growth phase. Okay, so the infant growth phase account for about 15% of the adult height. So it is actually affected by the good nutrition. The child must also have good health and happiness, and thyroid hormones also plays roles in the growth of the child at this phase. Okay, and then we have the childhood phase. So this is rather a long and steady phase of the growth, and it accounts for about contributes to about 40% of the adult height. So at this phase, the genetics of the child will play roles in the growth. Apart from that, good health and happiness are also important, as chronic prolonged unhappiness will actually lead to psychosocial short stature. Other than that, growth hormone and thyroid hormones also plays role in this growth phase. And the last one is we have the pubertal growth spurt. So these contribute to about 15% of the total of the eventual height of the child. So at this phase, the sex hormones, which are mainly testosterone and estrogen, will plays role. So as the as a child experience puberty, their sex hormones will start to be secreted. So the sex hormones will actually boost the growth hormone and cause fusion of the epiphyseal plate and leads to cessation of growth. And as you can see in the graph, as the female usually achieve puberty first, so their sex hormones will be produced earlier compared to males. So this will cause cessation of growth to be early in females, and that is why we can see in general population, the females are usually shorter compared to males. This is because the females usually experience puberty first, so they will have early cessation of growth compared to males. Okay, so these are the description that I have mentioned in the graph just now. You can read when you want to go back to the slides. Okay, next I will talk about the physiology of the growth hormone and how it helps in the growth of the child. So firstly, in the hypothalamus, so hypothalamus will secrete the growth hormone releasing hormone, GHRH, that will give effect to the anterior pituitary to secrete growth hormone. So growth hormone will give direct effect to liver and other tissues. So it will stimulate the production of insulin-like growth factors, IGF-1, that will have skeletal effect and also extraskeletal effect. So in the skeleton, the IGF-1 will actually increase the cartilage formation and the skeletal growth. In the extraskeletal tissue, it will increase the protein synthesis and also promote cell growth and proliferation. Other than that, the growth hormone also have anti-insulin actions, in which in the fat it will promote lipolysis, and in the carbohydrate metabolism it will increase the blood sugar and other will have other anti-insulin effects. Okay. Okay. Next is I would talk about the sex-adjusted mid-parental height. So as height is actually highly correlated to the genetics. So specifically the parental height. So the calculation of the mid-parental height is important when you want to assess the growth in a child in order to avoid misclassification of the child, misclassification of the abnormal growth. So MPH is actually one of the assessment that you must include in your workup in child that presented with abnormal stature. Okay, so how you want to calculate it? So for boys, you need to plus 13 centimeter to the maternal height, and then add the paternal height and divide by 2 to get the average. Meanwhile, in girls, you need to minus 13 from the paternal height and then add the maternal height and divide by 2. So the value would be the genetic target height range. So the value would be plus minus 2 standard deviation. So the child should achieve the genetic height within that range of value. Okay. Okay, next is important to know the average height velocity. This is also one of the assessment that you would want to look at when you do the workup for the short stature or tall stature. So it is actually a dynamic value. So the velocity different according to the phase of the growth. So in the prenatal growth or in intrauterine fetal growth, the child will usually grow about 1.2 to 1.5 cm per week. In infancy, the rate would be 23 to 28 cm per year. In childhood, it is 5 to 6.5 cm per year. And in puberty, the girls and boys would be different lah. Girls is 8.3 cm per year and boys would be 9.5 cm per year. So in order to determine the average height velocity, you need to have serial measurement of the the height of the child, and then look at the graph. Okay, plot it on the graph to look at the velocity. So let's go into the disorders. Firstly, we will start with short stature. So according to Nelson textbook of Pediatric 21st edition, the definition of short stature is growing either below expected genetic potential, which is 2 standard deviation below from the mid-parental height, or when the child is growing below 3rd percentile from the growth chart, it is negative 2 standard deviation for the age and sex. And then the definition of growth failure is when there is achievement of height velocity that is less than expected for the child's age and sex, or when there is downward crossing of more than 2 percentile lines for height on the growth chart. Okay, so these are some of the common etiology that you need to consider when a child presented to you with short stature, or basically these are the differential diagnosis that you need to consider. So it can be a variation of normal, which may be familial short stature or constitutional growth delay. Later on, I will discuss the difference between the familial short stature and the constitutional growth delay. Other than that, it can also be caused by intrinsic short stature, such as when the child is have a history of SGA, or maybe you suspect genetic syndrome such as Down syndrome or Turner syndrome or Noonan syndrome, or the child can also have skeletal dysplasia such as achondroplasia. Other than that, when the child also have systemic diseases, this will also affect their height. which leads to short stature. So some of the diseases can be HIV, TB, cardiac disease, renal disease, gastrointestinal disease such as cystic fibrosis or inflammatory bowel disease, CNS disease, chronic lung disease, and also malignancy. You may need to consider endocrinopathies as also your differential diagnosis. Among them are hypothyroidism, hypopituitarism, isolated growth hormone deficiency, growth hormone insensitivity, Cushing syndrome, poorly controlled DM, precocious puberty, pseudo-hypoparathyroidism, and pseudo-hypoparathyroidism. Other non-organic cause can be psychosocial deprivation, as I mentioned just now, when the happiness of the child is actually important in determining the growth of the child, okay, in the childhood phase. Other is nutritional dwarfing. Okay. So one of the cause that you need to consider is the variations of normal, right? So variations of normal can either be there is familial short stature or when the child is actually having constitutional delay. So the difference, the features that you need to look at is firstly the parent stature. So uh, in familial short syndrome, so one or both of the parent can be small. However, in constitutional delay, the parent stature would be average. And then the parent's puberty in familial short stature is the normal timing. However, in constitutional delay, so it's oftenly delayed. And then the birth length would be normal or low normal in familial short stature. However, in constitutional delay, it's normal. And then the growth from 0 to 2 years in the familial short stature would be normal. However, in constitutional delay, it's slow from infancy to the mid-childhood. And growth in 2 years until puberty would be normal in familial short stature. However, in constitutional delay, it's slow. And then the bone age, later on I will explain more about bone age. So bone age in familial short stature is normal. However, in constitutional delay, it's the bone age is delayed. And then the timing of puberty is normal in family short syndrome. Constitutional delay, it's delayed. Pubertal growth is the rate would be low normal in familial short syndrome, and in constitutional delay, they will usually the growth spurt is delayed and the rate is slightly diminished. And in adult, and the final height in familial short stature would be short lah. However, in constitutional delay, later on, the eventual height, they will achieve the normal height. Okay, so this is graph to differentiate between familial short syndrome and constitutional delay. So as you can see in the familial short syndrome, the growth of the child would be below the normal, below the two standard deviation. Okay, and the final height that they will achieve will not be normal lah compared to the normal population. However, in constitutional delay, this is the height, right? So this is actually the target height. So they will have delay in the childhood. However, in the late pubertal growth spurt, they will finally be able to catch up to the eventual height, the normal height of a person. Okay. Okay. So other than that, I mentioned just now, genetic syndromes can also be your differential diagnosis. So among them, you need to consider when the patient have Down syndrome or Turner syndrome, Prader-Willi syndrome. Prader-Willi syndrome is there is can be deletion in the chromosome 15 or uniparental disomy of the chromosome 15. So they will usually have faltering growth in infancy, which leads to the short stature. And other features to look for in Prader-Willi is they have hypotonia and hypogonadism, and then hyperphagia and hyperglycemia. Okay, remember 2 hypo and 2 hyper. And then another example is Noonan syndrome. Noonan syndrome is an autosomal dominant disease. So these are the features that you would look for in Noonan syndrome. An example of skeletal dysplasia, one of it is achondroplasia. So achondroplasia is an autosomal dominant disease and it is caused by mutation in the fibroblast growth factor receptor. Okay, these are the features. You can read them on your own. Okay, so how would you approach them clinically? So you need to get a good history. Okay, so firstly, in the antenatal history, you need to ask if there is any complication of the pregnancy, such as if the patient have intrauterine growth factor, it will eventually have a long-term effect on the growth of the child. Okay, other history, if there is any preeclampsia, hypertension, maternal smoking, alcohol, or infections antenatally. And then for birth history, you need to get the gestational age because like very low birth weight would be would affect lah, have long-term effect on the growth of the child. Then you need to get the birth weight length and then mode of delivery and also the APGAR score. Then ask for any neonatal complications, developmental milestone of the child. You also need to be particular about the nutrition because especially in infancy and in childhood, nutrition is important factors that will determine the growth of the child. So ask about the general well-being, the appetite, energy, sleep, bowel habit of the child, and also the patterns of growth from birth. Then ask about maternal and child relationship to rule out psychosocial short stature. Medical history, ask for any underlying illnesses or medications that the patient is currently taking. For family history, ask for any short stature that involves 3 generations if you suspect it's a familial short stature, and then ask the age of onset in puberty of the same sex if you suspect it's a constitutional delay short stature. Okay. And then for physical examination, you need to you need to do the anthropometry measurement. You need to get the height, weight, head circumference, and plot it on the growth chart according to the age. And then based on the growth chart, you would also want to look at the height velocity. And then you can also measure the upper lower segment ratio and arm span. All this I will explain further later. Other than the anthropometrical measurement, you need to also measure the height of the parent in order to calculate the mid-parental height, and then look at the general appearance and behavior of the child. If you're suspecting any genetic disease, look for any dysmorphism, and you also need to do pubertal staging of the child. Okay. Okay, so the techniques to a correct measurement of the height is important. Okay, you need to be very accurate in the measurement of the height. So for age below 2 years old, you would measure the recumbent length using the infantometer. So to measure the length, you need 2 people. Okay, one to hold the child in position and one to take the measurement. So other than that, you need to remove all the hair ornaments or hairstyles that will interfere the measurement and interfere the positioning of the child. Okay, so the child will be positioned in an inflexible measuring board in Frankfurt plane, and then you need to make sure that the outer canthi of the eye is in line with the external meatus of the ear and are perpendicular to the long axis of the child, and then make sure the legs are fully extended and the feet are perpendicular to the plane of the supine infant. Okay. And then for child age 2 years above that can stand on their own without support, you use the standing height using stadiometer. Okay, so make sure you calibrate the tool well, and then while standing, make sure that the back of the head, the thoracic spine, buttocks, and feet are close to the vertical axis of the stadiometer. Okay. And then just now I mentioned about upper to lower body segment ratio, right? So so how you measure the upper to lower body segment ratio? Firstly, you measure the total height, and then For lower segment, you take from pubic symphysis up until the floor, so measure. So that is how you get the lower segment. And then how to get the upper segment, you just minus the total from the, you minus the lower segment from the total to get the upper segment. And then the normal ratio after 7 years, it should be 1:1 lah. The upper to lower segment ratio. So when that is higher upper to lower ratios, it is a characteristic of short limb dwarfism. For example, in Turner syndrome. However, if they have lower upper to lower body segment ratio, it may suggest hypogonadism or Marfan syndrome. Okay, next one, you can also do arm span to height ratio. Okay, so how you measure it is you take the distance between the tips of the middle fingers to measure the arm span, and then you must position the patient in standing position with back against the wall and arms outstretched horizontally at a 90-degree angle to the trunk. So, so for arm span to height ratio, after 15 years of age, the normal arm span to height ratio should be
Zoni, you ada berapa
about
slide sebenarnya ni?
30 something, 30 something, doktor.
Ya, berapa slide sekarang?
Sekarang tak sure. Ni slide ke berapa? Lagi sikit je, Datuk.
Ya. Kalau you are given benda yang tak apalah, you want to know, okay lah. Tapi di master level punya. Tak apalah, continue.
Oh,
Continue.
alright.
Continue, tak
Okay.
apa.
So if it's more than 1.05, it indicates a pathological tall stature like Marfan syndrome and hypogonadism. Okay, next we move on to the investigation. So firstly, of course, you need to do the general test in order to rule out the systemic disease. Okay, so do FBC, renal profile, liver function test, ESR and urinalysis. Now if you suspect it's a genetic disease, do chromosomal analysis. And then if it's you are suspecting endocrinopathies, do endocrine tests such as TFT, growth factor IGF-1 and growth hormone stimulation test. And then for imaging, you do the bone age, CT, MRI, or CT or MRI brain if you're suspecting it's a neurological cause. Other investigation would be blood gas analysis or radiograph of the spine uh, to rule out other systemic illness. Okay. So just now I talked about the bone age. Okay, so how you want to determine the bone age? Firstly, you take the radiograph of the left hand and wrist of that child. So this will provide information about the skeletal maturation. So why we want to know about the skeletal maturation is because skeletal development represents the physiologic rather than chronological age of that child. So if you look at the X-ray and there is delayed bone age, so in which means the skeletal age is younger than the chronological age of that child. So there can be a catch-up potential for linear growth. However, if the child already has an advanced bone age, so it shows that the child's bone actually have rapid maturation and there is chance of earlier cessation of growth. So this is actually helpful in predicting adult height in early or late maturing adolescent. Okay, so you use the usually they use the atlas of Grulich and Pyle to determine the bone age. Okay, so for management, you need to treat the underlying cause lah. And then for children you suspect to be growth hormone deficiency, refer to PEDS endocrinologist for initiation for growth hormone treatment. And then you also need to
Sekejap. Ini kan tendang ini. Itu pump.
Water pump.
Waktu pump air, pump batas pump tarik air atas. Setelah waktu kita pump kita dalam mampu pump ini. Atas ada di bawah. Atas ada bawah di bawah. Oh ya. Distributing process on. Because this is because
Dia kalau dalam switch direct ni.
boleh. Dapat awal itu.
Kalau dah school, kalau 3 by ESD short dia. Kalau ESD dah 3, cuma MCQ dia. Mungkin dia kalau dah tu sudah lama pakai kertas. Dia lama dia.
Si mau
Biasanya.
Tahan semua orang berat. Dari satu tak pakai, satu tak pakai satu. Dari atas, dari satu tak pakai. Dia nak dia ke bawah, sampai ke atas tak ada satu. Saya mau pasal pipis lah kalau mau naik.
Yang lebih lalu.
Siap betul? Siapa yang mengajar orang tu?
Okey.
Sambung lah. Okey. Oh, dekat mana? Dekat asrama ke?
Dekat bilik.
Bilik okey
Alright. Okay, so continue with the management. You need to also provide psychological support for non-treatable cause. For example, if it's a genetic or familial stature, give psychological support. And then, so indication for growth hormone are as mentioned below. So, dibaca. So how to give the growth hormone treatment? So it should be initiated by pediatric endocrinologist. Ini doktor nak saya explain ke?
Tak payah.
Okay,
You
tak
tak
payah. Ini ada dalam
you tak jadi pediatrician lagi.
Okay.
Ini
Next.
you see okay
Okay.
Betul.
Alright. Okay, so next is growth disorder in tall stature. So definition.
Berapa slide ni?
Okay, yang ni sikit je Datuk sebab
okay,
explain causes, lepas tu history MPA sama je macam tadi. Management yang untuk growth hormone tu je.
Okay
Okay.
Continue.
So
Tak dengar.
So definition of tall stature is sekarang dengar tak?
Dengar.
Hello? Okay.
Dengar.
Okay, so actually tall stature is an uncommon complaint lah. In fact, tak dengar?
Dengar.
Sekarang dah dengar tak?
Dengar.
Alright, okay. So the common etiology for tall stature, so of course it can be variation of normal. You suspect familial tall stature, and then endocrinopathy such as growth hormone excess, precocious puberty, congenital adrenal hyperplasia. In genetic conditions are such as Marfan Syndrome, Klinefelter syndrome, Soto syndrome. Obesity can also promote tall stature. Other than that is excessive growth at birth. For example, if the mother has maternal disease or the child have a primary hyperinsulinism. Okay, so familial tall stature is the most common cause lah for a complaint of tall stature. So it is a variant of normal, no detected pathological cause, and important for you to calculate the mid-parental height to determine it is a normal variant. So the clue suggesting familial tall stature is that they have history of family history of tall stature, no dysmorphic features, the height velocity is in high normal range, and the bone age is normal. Okay, other cause is excess growth hormone secretion, like for in children is gigantism lah. So you need to be able to differentiate between acromegaly and gigantism. Okay, so acromegaly it occurs in adulthood, however gigantism in childhood. So other features that you need to look for if you're suspecting gigantism is that they will have facial features of prominent forehead and protruding jaw, and then the onset of puberty will also be delayed in gigantism. Gonadal development is reduced or often hypogonadal state, and the cause can be pituitary adenoma and so on. Okay. Syndromic cause are Klinefelter syndrome, in which they have the chromosome is XXY, so it occurs in male. So they are usually tall and slim, and they will have long legs compared to their trunk, and they might also present with learning difficulties. Other is
Sebelum tadi. Okay. Continue ke depan.
Alright, next is Marfan Syndrome. It is an autosomal dominant disease. So they will have increased arm span to height. They will have a Steinberg sign, the thumb sign, Walker-Murdoch sign. Okay, this is Walker-Murdoch sign. They will also present with problems such as aortic or mitral regurgitation and also scoliosis. Okay, another syndrome is Sotos syndrome, which is cerebral gigantism. So the weight and height at birth would be above 90th percentile. They will usually have enlarged head. So it is caused by mutation in the NSD1 gene. So clinically, you can look for macrocephaly, prominent forehead and jaw, hypertelorism, okay, increased distance, and then high arc palate, large hands and feet with thickened subcutaneous tissues. So investigation, samalah macam in the short stature. Okay, you can also do MRI of pituitary. Okay, if you're suspecting the patient have a pituitary adenoma that leads to gigantism, serum cortisol, serum prolactin. Okay, so the management, I would just provide the management for pituitary gigantism lah. So you can give octreotide, which is a somatostatin analog that will suppress the GH production, and however, you need to bear in mind that they have significant GI side effect. The drug is pegvisomant, which is a selective growth hormone receptor antagonist. So it will compete with the endogenous growth hormone for binding to the GH receptor, and it will also help to suppress the GH production. Other than that, you can also give high dose steroid because you want to promote epiphyseal closure in children that you suspect to have gigantism. Okay, so these are my references. That's all from me. Thank you. Are there any question? Or Dato, would you like to add anything?
Tak payahlah, cukup dah tu.
Alright.
More than enough, tapi I don't know. You rasa boleh banyak sangat benda tak? I tak tahu lah. Okay lah to know those
Banyak
things. Tapi you nanti takut dengan pediatry. Banyaknya lah benda. Because they are at your level, you have to know 50% of that only. Tapi tak apalah.
I think yang important to know in short and tall stature ni is the differential diagnosis, right?
The definition, how you recognize, and then how you recognize, and then the definition, and then after that you have to know the possible diagnosis. Itu sajalah, itu few things. Tapi itu pun kan banyak daripada apa saya belajar masa saya jadi mereka student. Tapi tak apalah, you suka benda yang complicated, tak apalah. Okay siapa next presenter
Saya. Okay, next is
this is topik yang I worry. I tak tahu kenapa nak masuk topik ni masa you all lah. Rasa very complicated for you all. Tapi tak apalah continue
Kita skip je ke Dato? Kita skip je ke?
Tak apa. No, this topic you have to recognize, right? But then you know when to refer. There's when you become a medical officer. Or ni, we don't expect you to investigate. Like short stature, we don't expect you to investigate. Once you become pediatrician, then only you investigate. You understand? It's not for you to investigate, and it's not for you to counsel the parent. Unlike we the one who counsel the parent because they dangerous. Salah cakap we dangerous. Okay dah. Sekejap Sekejap. Ada orang buat kerja kat rumah. Rumah saya tak ada api tadi. Sekejap.
Okay.
Ni, awak kata mau buat ni bila mau buat?
ke ataupun tak beli? Okey. Saya boleh check lah. Saya sudah UI tau. Saya sudah UI sini. Kita dah sudah UI dah. Sudah masuk mengajar balik. Come.
Okay. Datuk, kalau saya start melalut, Datuk tolong bawa ke jalan yang lurus.
Okay, ha.
Okay, so what first of all is the definition of inborn error metabolism. So from the name inborn error metabolism, inborn it means it is a genetic disorder, and then error metabolism means it is there is a defect in the metabolic pathway. Okay, so usually the inborn error metabolism are either transmitted by autosomal recessive or X-linked. So example of autosomal recessive is galactosemia, maple syrup, and so on. Okay, so I've attached this diagram dekat sebelah ni. Okay, so it is the pathogenesis lies in this diagram. So basically the pathogenesis of inborn error, it is first the accumulation of substrate proximal to the block pathway. Okay, so this is the block pathway. So the accumulation of substrate is usually A and B. A and B is usually the accumulation of substrate. So accumulation of substrate can be toxic to the body lah. And then if this is the block pathway, then C and D cannot be formed. So another pathogenesis is deficiency of the end products distal to the block pathway. And finally, when there's this block pathway, our body tend to have another alternative pathway causing the product formation of product E. Okay, so these three are the pathogenesis of IEM lah. Okay, next. Okay, so epidemiology. Epidemiology is actually a not so common disease. So paling common pun MSUD, G6PD macam itulah. Okay, next. Okay, so classification of inborn error metabolism, it can be classified based on the error involved in metabolism. This is a much simpler metabolism, much simpler classification, because if there's a defect in the amino acid metabolism, then the example can be Phenylketonuria, homocystinuria. If there's disorder of carbohydrate metabolism, then the disease would be galactosemia, glycogen storage disease, and then macam ni lah. Okay, disorders of porphyrin metabolism, purine pyrimidine metabolism. Yang paling penting yang amino acid carbohydrate metabolism tu. Okay, next. This is from the quiz protocol. Okay, tak payah Datuk ni.
I tak ingat semua. You dah ingat semua, ingatlah.
Tak payah kot. Yang ni kena ke? Ini macam banyak sangat.
Oh. You nak belajar semua ni. I okey je. I tak ingat semua. I tak tahu. I tak ingat. I tak tahu lalu. Ya, yang tahu semua.
Tapi tak tahu yang mana yang penting pun nak ingat.
Ya, yang penting is only the urea cycle defects, sugar intolerance, galactosemia. Pusing balik. Itu yang penting oleh Yang penting Phenylketonuria, galactosemia, glycogen storage disease. Lepas tu pusing ke depan. Forward das sugar intolerant, urea cycle defects, lepas tu glycogen storage disease, itu yang you perlu tahu. Lepas tu forward lagi. Forward lagi. Oh. Ya, tahu semua ni. Wah.
Tak payah.
Tak payah semua ni. Forward.
Okay, dah habis dah tu je. Betul approach dah.
Okey Okey
Selamat.
Okey,
Okay,
forward
next.
lah. Ada tahu topik ni masa tinggalkan you all tak benarkan topik ni masuk. Sebab topik ni menyebabkan orang
Okay.
takut dengan pediatrik. Okey continue.
Kalau masuk MCQ macam mana Dato?
Tak tahulah you all. Kalau yang biasa yang buat MCQ yang suka macam ni ada Tauri. Dia hafal semua.
Oh, ya.
I tak hafal. Okey
Allah, mampus macam tu. Macam mana ni?
Tahu tak? You pujuk Dr. Alwi yang masukkan. Okay, continue.
Allah. Yelah, next. Who should be suspected? Ini yang paling penting. This is our level lah kan. So basically the clinical suspicion on acutely ill child. So the clues for diagnosis include consanguinity history, clinical deterioration after feeding, because macam yang tadi glycogen storage disease semua tu dia orang akan present with hypoglycemia, and then acute encephalopathy, unexplained metabolic acidosis or hypoglycemia, history of unexplained sibling neonatal death, maternal history of HELLP syndrome. So yang HELLP ni HELLP syndrome, and then unusual smell and sweaty feet. Dia selalu kalau dalam maple syrup dengan Phenylketonuria akan ada unusual smell ni. And then the clinical presentation, basically dia orang tak ada a very specific clinical presentation. So dia orang punya clinical presentation selalunya is usually very vague clinical presentation, and it usually involve multiple system. So the common presentation will be poor feeding, vomiting, lethargy, seizure, and also coma lah. And patient can also be hypotonic. Okay, next, investigation. So when you see this patient, you see the clinically ill child, so you have to proceed with the investigation lah. So you have to know whether this is a metabolic disorder or infection, trauma, or CNS anomaly. So for the metabolic disorder, you need to obtain the plasma ammonia. Plasma ammonia is very crucial lah. So if there is hyperammonemia, and then you have to obtain the blood pH to know the anion gap. So how you calculate anion gap? Na plus K plus, and then you minus the cation minus the anion lah. So if there is hyperammonemia, you have to calculate the anion gap. If there is normal anion gap, then it is urea cycle defects. But if there is high anion gap and the patient has acidosis, then you have to suspect for organic acidemia. So I will elaborate further lah apa benda urea cycle, organic acidemia semua ni. And then if the ammonia level is normal and the anion gap is also normal, then you suspect for aminoacidopathies or galactosemia. Okay, so the basic metabolic investigation yang macam tadi lah, ammonia level, glucose sebab dia selalu present with hypoglycemia, lactate sebab they also present with lactic acidosis, and then blood gases to know for the metabolic acidosis tu lah. And then the special metabolic investigation. Next. Okay, so basically from the blood investigation, if you see there is ketosis without any acidosis, lactate level high or ammonia level high, then you have to suspect for maple syrup urine disease.
Proceed lah, tak payah Continue.
Nice.
Okay,
next. Important IEM ni. Ni aminoacidopathy ni. Okay, so first is phenylketonuria. So from the name, Phenylketonuria, we know the cause is phenylalanin hydroxylase enzyme deficiency. So bila enzyme ni, the problem in this enzyme, so phenylalanin cannot be converted into tyrosine, right? So the effect is there will be low level of tyrosine, and then there will be accumulation of the substrate tadi cakap and the phenylalanin. And then alternative pathway is this phenylalanin will be converted into phenylpyruvate. So the principle of treatment dia senang je. So bila low level of tyrosine, we just give tyrosine supplement. And then bila terlalu high phenylalanin ni, kita just restrict the diet tu lah, phenylalanin containing diet tu. Okay. Okay, so clinical features dia, intellectual disability is the number one, maksudnya phenylketonuria is causing the number one mental retardation lah. Sebab terlalu banyak phenylalanin can cause mental retardation. Okay, next. Okay, next is maple syrup
Semula
urine
semula ke
disease.
belakang semula? Ke belakang semula.
Ha.
Okey. Okay, forward. Forward. Okey, MSD, okey bang. Ke depan lagi.
Okay.
Okey,
Okay, next is MSUD. So maple syrup urine disease pula is there is a deficiency in the enzyme for the branch keto acid dehydrogenase enzyme deficiency. Yang ni, yang branch chain amino acid ni, transferase ni dia deficient. So when it is deficient, so there is lack of catabolism of leucine, valine dengan isoleucine. So bila terlalu, dia akan cause accumulation of the substrate ni lah. So the clinical features is usually lethargy, convulsion and coma. Cerebral edema is the hallmark of MSUD ni lah. And then for the investigation, you can do amino acid analysis, semua ni. Okay, so for the treatment dia senang je. Restrict BCAA diet je. Kan Dato', tu je kan? Nak tahu?
Okey.
Okay, next. Next is urea cycle defects. So for the urea cycle defects ni, dia setiap pathway ni nama dia lain-lain lah. So first
Marfan
is
tu?
the tak payah.
Tak payah tak sebut lah.
Okay, tak payah sebut. Next, clinical features dia. Clinical features dia sama, dia selalu vague je pun. Lethargy, irritability, vomiting, convulsion. So patient ni, this patient usually have cerebral edema because of the hyperammonemia ni lah. Okay. And then for the diagnosis, you need to look macam tadi, I mentioned about serum ammonia. When it's high, then you have to measure the anion gap. So if there is high ammonia but normal anion gap, then you have to suspect for MSUD. And then for the long-term management ni, protein restriction je lah, penting.
Okay.
Okay, lastly, organic acidemia. Dato' ni tak payah kan? Saya termasukkan.
Just mention little bit je.
Okay.
Serum ammonia level and symptom dia lah. Very it's very it's acidosis. You know acidosis because it's ni the basic is the gonna acids. Because then they got itulah intellectual disability dia mendelay itu je. Okay. Buku belakang 10 backward. Backward. Forward. Ke depan lagi. Dulu kita masa nak exam master tu kita hafal semua ni.
Allahu Akbar.
Senang je. Sekarang dia just remind dia. Tak ada apa.
Datuk Tera.
Ramai orang boleh buat.
Okay, baiklah.
Forward lah.
Dah habis tu je.
Tu je, okay.
Okay, next.
Okay. Ada question pasal ni about ni IEM. It's rare but it's mainly can be treatable and one of the main cause of the intellectual defect and itu ni. Okay, next.
Okay, Assalamualaikum. So lastly, I would like to share about sepsis and septic shock. So next slide. Okay, so firstly I'll share the definition about certain important definitions such as infection, sepsis, sepsis, and also septic shock. So what is infection? Infection is when there is a infection caused by any pathogen which is not part of the normal flora. So this can be proven by positive culture, tissue stain, or PCR. So next is SIRS. What is SIRS? SIRS is a widespread inflammatory response which may be with or without infection. So the criteria for SIRS has to be more than or equals to 2 of the following, which is the core temperature higher than 38.5 or less than 36, with tachycardia or bradycardia in children less than 1, or tachypnea, and also leukocyte count, which is elevated or depressed for each or more than 10% neutrophils. Next is the definition for sepsis. So what is sepsis? Sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. So dia ada infection, lepas tu dia punya immune response tu dysregulated and over sangat, yang dia akan cause a life-threatening organ dysfunction. So it's basically cyst with infection. So what is severe sepsis? Severe sepsis is bila dia punya sepsis tu associated with cardiovascular dysfunction or associated with ARDS, acute respiratory distress syndrome, or dia ada dysfunction in more than or equals to 2 organ systems. Finally, is septic shock. So septic shock is when there is severe sepsis with persistence of hypoperfusion or hypotension despite adequate fluid resource. Or there is a need for vasoactive agents to maintain the blood pressure. Okay, so next. So this is the dysfunction lah, organ dysfunctions, the criteria for the organ dysfunction. Ni sambungan juga. Ni boleh baca sendiri kot. Okay, next lagi. Okay. So like next is COVID-19. This is a new topic, which is COVID-19 multisystem inflammatory syndrome in children. So this is in children, COVID-19 presents with a Kawasaki disease-like or toxic shock syndrome-like features in children with evidence of COVID-19 infection or exposure. So usually they are associated with cardiovascular and GI system involvement. And many children who has multisystem inflammatory syndrome shows myocardial dysfunction and also requires cardiovascular support. So next, I will share about the pathophysiology, risk factors, and organisms. So sepsis is caused by the release of pro-inflammatory mediators, which exceeds the boundaries of the local environment, leading to a more generalized response. So there is multiple factors which contributes to sepsis. Firstly is the effect of microorganisms. So the microorganisms release the toxins and activates the complement, coagulation, and also fibrinolytic system, which leads to microvascular thrombosis and the production of vasoactive products. So when additionally there is an excess pro-inflammatory mediators, which may spill into the bloodstream, and such as tumor necrosis factor alpha and interleukin-1. So this pro-inflammatory mediators is the one which causes the symptoms such as fever, hypotension, leukocytosis, and also it will induce other pro-inflammatory cytokines and will activate the coagulation and also fibrinolysis. Additionally, the complement activation also plays an important role in sepsis. So the activation, next slide. So the activation of complement system and also the coagulation system and also the release of endogenous mediators will cause a systemic effect of hypovolemia, cardiac and vascular failure, capillary leak and endothelial damage, acute respiratory distress syndrome, the IVC, and also decreased steroid synthesis. And this will lead to shock, and if untreated will cause multi-organ dysfunction syndrome. And if kalau terus sangat, then it may cause death. So these are some.
Belakang balik. Pusing ke belakang. Backward. Okay, stop sini. Okay, forward lah. Okay, forward lah.
Okay. So these are some of the risk factors for sepsis. So firstly is in neonates, age less than 1 month, those with serious injuries such as major trauma or burns, those with chronic debilitating medical condition, those with host immune response suppression, such as those with malignancy, HIV or severe malnutrition, or patients with large surgical incisions, those with catheters or devices such as endotracheal tube or chest tube, and also those with urinary tract abnormalities because increased chance of UTI. Okay, next is the common pathogens. So the organisms which usually contribute to sepsis can be either bacterial, viral, or fungal, or others. So bacteria such as Staph aureus, cons, strep pneumonia, Pseudomonas aeruginosa, and also meningococcal. In virus such as influenza, adenovirus, RSV, dengue, EBV, and CMV, and also currently COVID-19. So others such as fungi and parasites. So fungal causes of sepsis is especially in those with children with malignancy who are immunocompromised, and those with indwelling vascular catheter, or those with recent broad spectrum antibiotic use. Okay. So next is the clinical features. So in this table, so in this table, these are the clinical features for infection. So firstly, you have to identify where is the source of the infection. So is it upper respiratory tract infection, lower respiratory tract infection? So here you can read by yourself later the symptoms for each infection. Okay, next. So this is a continuation. And okay, so lagi. So next is the clinical features for septicemia. So from the history, there will be the important history that you have to take is the history of fever, the poor feeding, where the child was miserable, irritable, and lethargic with altered mental status, and a history of focal infection anywhere in the body, and also any predisposing conditions such as immunodeficiency or sickle cell. So from examination, you have to look for there will be fever, tachycardia, tachypnea, hypotension in severe or advanced shock, and also purpuric rash, which is non-blanching, such as which is indicative of meningococcal, and also as a shock, and also multi-organ failure. So next is the clinical features of shock. So in children, well, usually in adults, they are presented with warm shock, right? But in children, they are presented with cold shock. They are usually presented with cold shock. So the differences between warm shock and cold shock is that warm shock will have warm flashed peripheries, and the capillary refill time is less than 2 seconds with bounding pulse, tachycardia, and the blood pressure is relatively maintained, and the pulse pressure is widened, and the hemodynamic abnormality is because of the vasoplasia, and it's more common in older children and adolescents. But in infants and neonates, they are presented with cold shock, where there is cold, clammy, and cyanotic peripheries, and the capillary refill is more than 2 seconds with a weak and feeble pulse rate, and the heart rate is weak and feeble pulse, and the heart rate may be tachycardic or bradycardic, and the BP is hypotensive. The pulse pressure is narrowed, and the hemodynamic abnormality is due to septic myocardial dysfunction. Okay. So hypotension is usually in children. The earliest symptom is the earliest sign that you can get, which is suggestive of shock, is the tachycardia. So hypotension is a late sign of shock. As in children, the BP is maintained by increased heart rate, systemic vascular resistance, and also the venous tone. So next is the investigations which needs to be done. So sepsis is clinically diagnosed, but investigations is very important to identify where the evidence of any hematologic abnormality, electrolyte disturbances, and to identify the source of infection. So firstly, you have to check for the blood glucose, for is there any hypo or hyperglycemia, and look for the VBG or EBG for any metabolic acidosis. Check for the full blood count for any leukocytosis, lactate for you suspect it to be elevated due to lactic acidosis. Then look for any electrolyte imbalance, any blood urea, nitrogen, and serum creatinine imbalance, such as increase in dehydration, and also renal function. To assess for the renal function. and also the liver function test to look for any abnormalities in the serum bilirubin, AST, and also to evaluate the liver function, and also to look for any coagulation disorders such as to look for any prolonged PT, APTT, which may be suggestive of the IBC, and also look for any fibrinogen and D-dimer increase due to the IBC. Next is to identify the source of the infection. So you have to do blood culture to identify the organism, and also urinalysis urinalysis and also urine culture, and any other culture which are indicated, such as kalau perlukan, kalau dia presented with maybe meningitis symptoms, dan kena buat CSF culture. Kalau dia ada throat punya infection, then kena buat swab culture. Okay, next is kena buat chest X-ray if suspect pneumonia, pulmonary edema, or cardiac failure. Kena buat CT scan to look for any if there is any indication to look for intracranial hemorrhage, and abdominal CT to look for any abscess if indicated, and also ultrasound abdomen. So for the management of sepsis, so here you can see within 1 hour of the diagnosis of sepsis, we have to do all these
Detail
steps.
sangat. No need
Okay.
for you to know detail. Just
Okay.
examination, recipe support, chart, investigation, food station, preventive treatment, intervention. Nah, cukup dah.
Okay. So,
Bukan you nak
so
tahu
this is
detail tu.
okay. So ni lah important dia yang first ni. Okay, so next is respiratory support, empirical antibiotic. Kita start dengan empirical antibiotic.
Treatment is
Lepas tu fluid resusc, and also inotrope lah kalau tak boleh.
Forward fluid
Okay.
resuscitation and endotrophy suppressor cukup. Because itu pun tak agree cold dengan warm ni. Continue. Tak agree cold and warm ni Ni okay lah, you have to know adrenaline forward. Adrenaline, dopamine, dopamine cukup. Tak payah ada lain to effect, tak payah.
Okay.
Continue lagi. Tak payah. Continue. Tak payah. Tak payah. Apa you nak manage ke? Okay dah finish Kenapa nak menyusahkan diri benda macam tu? Menakutkan, jadi pediatric tu menakutkan. Okay, finish Okay. Ada apa lagi? Siapa lagi?
Dah habis tu je.
Tu je. Nanti siapa tu pilih WhatsApp semua nama-nama dan topik to me.
Okay, Dato. Beres.
Okay WhatsApp nama dan topik. Okay
Thank you, Dato.
Okay.